Hi, everybody. I am really excited and honored that we have Senator Bill Frist joining us this afternoon. Senator Frist served in the Congress of the United States for 12 years. He was a Senate Majority Leader. He is a transplant surgeon trained at both Princeton and Harvard. He started a venture capital firm called Frist Cressy Ventures. He's just a wonderful guy and has such insights into healthcare that I think it'll just be a pleasure to talk to him and ask him questions. So thank you, Bill. Thanks for joining us today, and I'm really looking forward to the conversation. So a couple of questions. Obviously, you live in the world of healthcare. You've lived in the world of healthcare your entire career since graduating from college and graduate school. So would love just to start off, just tell us what you think about where healthcare is today, where it's going. You know, how do we think as we like to think of ourselves as strategists. So where do you see the industry going, where it's been, and obviously there's a lot of change that's gone on in the most recent, in the last 2 years, basically with COVID, but where's healthcare going? What's going to change about healthcare today or tomorrow?
Yeah, John, first, it's great to be with everybody here today. I've been at healthcare in some shape or form for 45 years and grew up in a medical family, seen the private sector with the Hospital Corporation of America, which my brother started for the last 45 years, practiced for 20 years in the venture world, the private equity world. And I say all that, and I am never more excited about the future of healthcare as I am today. And not just because of the pandemic, but this sort of intersection of, yes, coming through the pandemic, but also the technology that's out there today, the big data that's out there today, the science, which we saw manifested with Operation Warp Speed in the vaccines, the whole world of synthetic biology that all of us will be focused upon, maybe not in the next year or 2 years, but 3, 4, 5 years from now. It's going to explode. The genetic code, which was a great public-private partnership when I was in Congress in the United States Senate, now just today really unfolding before us. So I am hugely excited about the future of healthcare delivery, and understanding that health of individuals is a lot more than just about the healthcare that we deliver, but it involves all those non-medical determinants, the social determinants, the well-being, how productive we are in life. That understanding now with the ability of technology and data to address it makes me more excited than ever.
So if you could think of a change that we'll see, I mean, obviously you talked about the science of healthcare, you talked about the delivery. Any nuggets you can share with us as you think that will, I don't want to lead you too far, but healthcare in hospitals, healthcare in home, things along those lines. And I know a lot of these things you're involved in, so that's why I'm probably leading you.
No, exactly. So if you want to go through more specifically, remote delivery of healthcare is exploding. We put it on the rubric of telemedicine, telehealth, virtual care. But literally it is exploding. I've been involved in the companies of starting Accolade and Teladoc and Devoted Health, all of which are focused very much now on remote delivery of testing and diagnosis and delivery. And just like the workplace for all of us outside of healthcare and end is changing, so is the actual testing and diagnostic and delivery model. So virtual healthcare exploded. Over the next 2 years, you'll see this whole world of primary care, sort of 3.0, with 1.0 is the way my dad practiced medicine and the way physicians did when I was in medical school, and 2.0 are the chin meds and the IORA. 3.0 is going to be a hybrid model that has been accelerated by COVID. And the companies I just mentioned, all of them, the Accolade, the Teladocs, the Devoted Health, all have this hybrid model that will have some bricks and mortar, but also will have primarily virtual healthcare in the primary care world. And then probably 2 to 3 years from now, much more specialty care that will be given both remotely. And I mentioned the third world of synthetic biology, and this whole world of synthetic biology that will be maybe 3 to 4 years from now, but begin now, where we are programming life, literally programming life just like we were programming the computer 20 or 30 years ago. And, you know, if you start going further, we have all sorts of trends going on, the explosion in the non-medical determinants of health, whether it's housing or access to internet or cybersecurity or food. We will see further consolidation of industry that we've seen. Smaller providers will increasingly see the efficiencies from whether it's administrative cost or patient populations or branding of being able to come together and share services and reach other populations. We'll see continued growth of Medicare Advantage. Medicare Advantage, a program that I helped start when I was in the United States Senate. And we passed a bill in 2004 and 5 called the Medicare Modernization Act. It invented Medicare Advantage and had 3 or 4 million people then. And now, as you know, it's delivering the majority of our Medicare today. So we'll see a whole bunch of trends like that under this rubric of increased technology, increased power of computing, more personalized medicine, because we're able to focus on individuals taking advantage of big data sets.
So Bill, I was going to ask you this question later, but I feel like it's a great time to ask it now. There seems to have been so much advancement since the early days of Medicare Advantage, you know, and the private, you know, the growth of it, and it just grows like wildfire. We don't see the same on the Medicaid, the state, you know, state-directed type of functions. Do you have a hypothesis as far as why has Medicare been so aggressively transforming the way we practice medicine or practice healthcare or deliver healthcare versus Medicaid?
Yeah, you know, when you look at Medicare and Medicaid, it's interesting, and I've been heavily involved in both. In fact, before I got into politics in the policy world back in the 1980s, I chaired a Medicaid commission. I got to know a Democratic governor. I was a Republican, and next thing I know, I'm in the United States Senate, in large part because of that. And at that point, we were moving Medicaid from a fee-for-service to a value-based system. And indeed, Tennessee became one of the most innovative states in the country later after that, in moving everybody to a more managed care where everybody was put into managed care. So big things backing up since that time. Medicare, predominantly through Medicare Advantage, because in 2005, and since then, we aggregate funds, we give it to an entity, and the entity decides how that's going to be allocated within that. So that allows for a lot of flexibility and a lot of nimbleness for innovation and change with times, and to experiment and to try things out in Medicare Advantage. This gave you that advantage that a fee-for-service system does not have. Medicaid, on the one hand, has 50 different, or 51, but 50 different states experimenting, innovating, trying things out. That's sort of the big picture. If you average out all the innovation in Medicaid among 50 states, because a lot of states don't innovate, you say, well, Medicaid is not really that innovative. But then if you look at individual states, you will say, there is a lot of innovation coming out of Medicaid. The big areas to me that are very exciting in terms of innovation is where you have Medicaid and Medicare working together. Yeah. Big areas of that, you have dual eligibles, the most expensive patients out there today. And there you have innovative programs like in Tennessee, Ohio, New York, who are integrating at the dual eligible level the best of what they have in Medicare and Medicaid, and looking at those patients holistically. So it's neat when you see them coming together. The second area, value-based care. Certain states, I would argue, are way ahead of Medicare in terms of value-based purchasing. And I'd throw Ohio in there, and maybe New York and Tennessee, that have been out there for years really pushing value-based care long before it's worked its way through the Medicare system itself. And a third area that is interesting just comes to mind, because we in the private sector are investing there, both at the mid-market private equity level and at the local level, but it's being adopted by states, is the focus, which is very innovative, on long-term support services, where it's not just medical care, but integrating medical care with the non-medical care. And that's being done predominantly through Medicaid programs, companies like CareBridge, based here in Nashville, and HHA, the sort of companies that are out there. So a huge amount of innovation occurring in Medicaid predominantly, that on average, if you average all 50 states, may not look like very much, but really are on the cutting edge.
Yeah, that's great. I could go much deeper and start talking about pace and other things, but we'll say that for another time.
Yeah.
So we can't have this conversation in October of 21 without looking back a little bit about the last 18, 20 months as far as the pandemic. Your thoughts as far as what we did right, what we didn't necessarily do right, what we learned, what we didn't learn, just some, from the seat that you sit in, what do you think about the pandemic and what we're doing and what we could probably be doing now to make it even, whatever this situation we're in, less painful?
Yeah, John, it's a great question, and we're all, the pandemic's not over, so we're still learning a lot. But I am encouraging cities and states to go back right now while it's still fresh and asking that same question. What were our biggest failures? What did we learn? What can we take from the past 18 months, 2 years, and apply to the future? If I had to start listing things, I'd say our biggest failure was that we were late to testing. The failure, you can point at the CDC, which a lot of people, Scott Gottlieb would point to the CDC. Other people would point to the lack of communication at the national level by the Trump administration. But I would say that the biggest failure was testing, and everybody was at fault, and a lack of integration early on with the private sector. The CDC basically didn't let the private sector come in, and the private sector was ahead of our government. And when there was a failure in the CDC test, we lost critical time and thousands of people died. Number two, I would say that we have today, that we didn't have before, a much greater sensitivity to the power of public health, to the deficiencies we had coming into COVID, but the fact that our public health infrastructure is absolutely critical. Not just hospitals, not just doctors, but our true public health infrastructure. And then the finger can be pointed back that we have not consistently provided the type of funding needed to provide a strong public health system. If you look just since the Great Recession, the last 13 or 14 years, if you look at funding for frontline state and local health departments, they have lost more than 56,000 jobs, positions, due to funding cuts just over the last 14 or 15 years. And if you look at CDC funding in the aggregate, you'd say, well, the funding has really increased at the CDC. But if you dissect where that funding is going, it's going to good areas like chronic disease, where we know we all have huge issues. But if you look at state and local health preparedness, funding has been cut by nearly a third over the past 17 or 18 years. I'd point the finger at the fact we prepared. We had some, preparatory test programs that were done, but all of those were aimed for the wrong pandemic. We were having these federal training exercises focused on the influenza virus in a pandemic setting where we already had vaccine models and we had influenza type testing, and we didn't model for the right things or what science had been telling us. The SARS or MERS that were much more likely to be the next pandemic. In terms of things we learned, the good things, and this is going to really play out, I think, as we write more and get a little bit further out, but the huge success of Operation Warp Speed. We didn't see it play out on TV or in the president's news conferences, which were a fiasco in many regards. But behind the scenes, we had this creation of multiple highly effective vaccines in record time. Right. 3 years ago, if you'd asked me, I would say it would have taken 5 years to get these vaccines, and we did it in 11 months. Thousands and thousands and hundreds of thousands of lives have been saved because of Operation Warp Speed. And it was a global effort, but our federal government, working with state governments, put huge funding into the private sector, and the private sector, through its innovation and nimbleness and smart science, delivered these products in record time. I think the other big success, and then I know we got to move on, is where I open virtual care and the understanding of the power of being able to deliver care virtually, whether it's in the diagnostic or in the treatment side of it, and the explosion in being able to do that remotely when hospitals were closed down and clinics were closed down and doctors were delivering and nurses delivering care from their homes over the telephone or by text messaging or by video. So those are some of the really negative things and the positive things that I continue to focus on as we're going back and looking at the last 18 months or 2 years.
So I feel that my next question may be a little bit of a softball, but it builds right off of what you were just talking. You were talking about public and private partnerships. And I know personally how you feel about a lot of these things, but I think it'd be great for our team to hear from you as far as the dynamic of the strength or the importance of public-private partnerships and how you see them playing out, or how they should ideally play out.
Yeah. Well, my bias comes from the fact I spent 12 years in the Senate and in the last 16, 17 years in the innovative side of companies and coming up with solutions. And I mentioned it just with Warp Speed, where the power of those two structures working together allows a crucible of fast innovation that can get to the patient. I used to say get to the bedside, because the translational aspect of basic science is something we've always struggled with, but it would take 15, 16, 17, 18 years in the past. And the fact that we can now do that in the course of 8 and 9 months is hugely powerful, but it's hand in hand. I think if we look at the government programs that we have today, I mentioned the innovation in Medicaid and Medicare and long-term support services. That really is a partnership of the public and private sector. Medicaid funded half by federal government and half by local state government, and Medicare funded by the American taxpayer through our federal government, but working with the private sector. In Medicaid, going from fee-for-service to value-based care, one of the big trends that will continue to come over the next several years. That value-based care, for the large part, is carried out by private corporations that everybody listening to us right now are working with, but it's within the framework of our federal government, our democracy, our representative government that is there. If you look at synthetic biology, which I mentioned earlier, the great breakthroughs that are coming our way now and in the future, a lot of that's coming out of basic research that began long ago with DARPA and in the many other similar basic science programs and basic technology programs that have been developed. So I love that synergy working back and forth, and people should not hesitate to invest around Medicaid and Medicare, where one of the biggest things, which I haven't mentioned, is that the administrative cost of our healthcare delivery system today, depending on what numbers you use, but say is 16% of the overall spend. And with artificial intelligence and technology, we know we can cut that in half. And that takes the best of the public and private sectors working hand in hand.
Great. A couple more questions, and these came from the audience. And the reason I'm sharing them is because we wanted to do a little crowdsourcing, and 2 questions that came up, which were, and I'll give you both of them together, but I think their answers will be very different. One is equity of healthcare, or equity of life expectancy equity. It's obviously there's quite disparate across the United States. One question is thoughts on that and how we kind of start to normalize that a little bit better. The second question is around vaccines. And there's a large portion of our population that is very resistant to getting vaccinated, even after all the successes with Operation Warp Speed and so forth. Any suggestions on how to help educate or comfort people that vaccines are not as bad or as people may surmise them to be? So those are 2 questions, one equity and one around the vaccine or the vaccine resistant population.
Yeah, and both of those are hugely important issues. And let's take the equity one. In my podcast and in my recent writings in Forbes, which I refer people to just if you want more information, most of it is being done on the health equity issues. And every boardroom now is talking in healthcare is talking about how we address the healthcare disparities, the healthcare equities that we know have always been part of our system and our sector. But with COVID, the disproportionate impact of these healthcare disparities has come to light. And as it's come to light, people know that they need to address it, that they can address it. So how are they addressing it? Number one, there a lot of communities are doing what we did in Nashville, Tennessee, here in Middle Tennessee, where we put together a large community health survey that identified the disparities that are in part geographic, in part racial, in part ethnic, in part the LGBT community. And the big thing is to get the diagnosis, to know where the issues are, how to address those issues. And the only way you can do that is to have a roadmap to do it. Number two would be to continue in the boardroom to address whether it's issues of diversity or inclusion so that we'll have a sensitivity to the issues in our own community. Mm-hmm. Have that discussion on what is structural racism. Even just those words to a lot of people, or to maybe 50% of people listening today, is offensive because you say, and we're getting to understand it better, you'd say, are you calling me a racist? And no, structural racism is a part of the history of our country that goes back for years and years and years. It has to do with redlining and education and access to housing and access to banking that wasn't intended, and it doesn't mean anybody's a racist, but which ultimately gets translated down to less opportunity for health or healthcare or opportunity to get that health or healthcare. And so those discussions to me are really powerful and should be a part of every community. The health equity, the trust issue is big in terms of who do you trust, who do you listen to in a community. And one of the issues like medical education, we haven't made a whole lot of progress on the equity issues. If you look at race, most medical schools today, in terms of the number of people that they are generating from a minority population, haven't really done that well. When I was in medical school, about 3% of all people graduating from medical school, this is 45 years ago, about 3% were African American. After all of these years and all our discussions, and with our knowledge that people tend to trust people of similar background a lot more, fewer people are graduating from medical schools today who are African American than were 45 years ago. So issues that can be taken. So we can move on, but anyway, we're making progress there. Everybody is addressing it at the board level in terms of diversity. We're recognizing locally in our own communities of these inequities and that there are things that can be done. The vaccine issue is one that comes back to trust. I just mentioned the importance of being able to hear from a trusted source, and that may be a faith-based leader, it may be your primary care physician, but anyway, you have to identify who that trusted source is and how we generate that trusted source in a community and recognize. We made some mistakes early on in terms of saying, well, we'll just put the vaccines out in pharmacies instead of channeling them through the primary care providers today. The vaccine hesitancy there is improving, I think, in our understanding of the misinformation on the internet and certain action that's being done locally and nationally. It's improving because of what we just have seen in the last couple of weeks with approval, at least a debunking of the myth or the argument that it's experimental. As the FDA comes in and approves the vaccines, it's no longer experimental. And as they approve these boosters, it's no longer experimental. So this is a number of the issues that are out there that I think we're making progress on because of discussion. And as consultants and as advisors coming in, I would encourage bringing those issues up and not to hesitate to use words like healthcare disparity, the fact that structural racism doesn't mean you're a racist, and understanding that there are different kinds of healthcare racism. I'll just mention now, I know we'll move on. We have a collaborative here called Nashville Health. Nashville Health involves our entire community, entire county, 700,000 people. With that, we did this community health survey that gave us the information so we'll know where to look for vaccine hesitancy, or will know where to look for healthcare disparities, and will know where to focus instead of trying to focus on everybody and everything to focus. It may be in certain communities itself. One of the findings, and I just wrote about it in one of these Forbes articles last week, is that our healthcare providers today, doctors in hospitals who are not, racially motivated, they don't think they have any bias. But if you talk to people out there through the survey and you get the information, there is a feeling among Blacks and Hispanics and probably other, populations, minority populations, that they feel 5 to 6 times from the doctor or from the hospital that they're being discriminated against because of race.
Wow.
Nobody intends it. And all that is to say that nobody's a racist, but to come in and we need to have those discussions. Why does a typical person coming in Nashville, Tennessee, a Silicon Valley of health services for America, we always say, and we like to brag about, why does your typical person tend to feel like, if they're a person of color or a certain ethnic group, that they're actively being discriminated against? That's tough information that we weren't aware of until we did this sort of survey in our community.
Yeah. Bill, I know we're out of time. First of all, thank you for it. It's been fabulous. This is everything and more than I expected. One last question just for the group. As we are practitioners, advisors, as you said, parting thoughts you give us as we go out and do our jobs and work with healthcare institutions and organizations in trying to advance healthcare. Any thoughts that you'd like to leave with the group?
No, first I'm honored because I know the group is a diverse group. When you put med tech and global health and biopharma and healthcare services, I think the big trends are attention is being paid to the individual. We used to say the consumer, but the person whose health really matters. It's no longer the big policy issue. So this focus on the consumer, and it might be through Net Promoter Score, it might be through satisfaction surveys, but that attention is something from the consulting world that's going to continue. I mentioned the administrative cost. I'm in the business of venture capital now and private equity, and 95% of what we do is addressed at making that provider patient, doctor patient, nurse patient more efficient and more effective, and continue to focus on that administrative cost. We've got artificial intelligence, all this parallel and supercomputing today. I mentioned this role of value-based care, but really consumer-directed virtual care is going to increase. We didn't talk that much about moving healthcare to the home, but with focusing on the individual, people want that care, whether it's virtual or in person. There'll be this increased movement to this home and on self-monitoring through the home. So we're going to have a more engaged patient with that. That's very exciting to me because all of a sudden you have 400 million people out there, exaggeration, but all of these people out there that are feeding into the system, and we're going to have a system that is much more responsive to the care and to the wishes and to the outcome and quality that's delivered to those patients.
Perfect. Senator Frist, thank you. This has been spectacular, so I really appreciate it. Thank you for spending the time with us. And I'm sure I'm thankful for our entire group. Thank you. Appreciate it.
Jon, great to be with you. Thank you.
All right, bye-bye.